11,000 people in the U.S. are confirmed infected. That's compared to around 1,000 1 week ago. Though that number, of course, is expected to grow. The death toll is also rising.
Right, I'm going to go through and mute people who aren't muted.
In the U.S. Okay. At this point yesterday, that number was 120.
Tell us who it is.
It might have been Bridget, because it went away when I unmuted.
Okay. All right, ready to go?
Sure.
Okay, let's get started then. Well, welcome everybody to our live lecture on pre-hospital management of crush syndrome. This is a truly joint talk that we'll be doing this afternoon, and we're really very fortunate to have also on the line not only multiple EMS colleagues throughout the state, as I understand, and I'm not sure what the count is right now, but I know there's several of you from our entire state of Maryland, as well as hopefully several of our Go team members that are online as well, and I'll explain what that is for those of you that don't know in just a minute. And in addition, we have our pararescue jumper unit from, and Dr. Rush, if you're on the line, I'll just introduce Colonel Rush, who at the last minute, we were able to get his medics online who are currently doing their paramedic class. So we're really honored to have you guys, especially. Was an unexpected surprise, and hopefully this is pertinent to your practice. We're gonna jump right into this here. This is a very basic talk. I have a lot of references to this. At the very end of this talk, there are QR codes. You can just scan that to your phone. It'll take you to an immediate link that'll give you full access to all the references, also to this lecture. So you'll have all that available in just about, gosh, 15, 20 minutes. It'll probably take us to get there. The goal here is really to make this collaborative. So what I hope we can do here is I can go through the information, give you a couple of cases, my thoughts about the cases, talk about some of the evidence and practice, and then maybe we can have some collaborative discussion. Because I don't think this is not going to take a full hour, but we have an hour if we want it. This lecture is also being recorded. So the objectives today are going to be to talk a little bit about epidemiology of crush injuries, mainly crush syndrome. We'll talk about the nomenclature in just a second. We're going to talk about the pathophysiology of injury and cell death, and also some treatment steps that you can use to prevent acute kidney injury and also the catastrophic complications that we see with crush syndrome. For those of you, again, my PJ colleagues, this is where we're broadcasting out of RM's Cowley Shock Trauma Center. And this is in Maryland. It's our primary adult resource center, over 7,000 admissions a year. We get about almost 20% by air, being a regional center, and about 40% of those are motor vehicle crashes. Our survivals are roughly just approaching 97%, looking at all comers. Disclosure information. Do not have anything really that's pertinent to this talk. I do have grant research support from the Department of Defense, nothing directly related to this, and I'm not going to discuss any off-label uses or drugs. I am a reservist, commander at Joint Base Andrews for an AMDS squadron, but none of that is related really to this talk. Okay, so the Go team, just a few words about the Go team, because this is why we're broadcasting this, is really to get some of the messaging out in terms of what our capabilities are. We're a team that's based here at Shock Trauma 24/7. We can go by ground or air. Usually prefer to go by air because it gets us to the scene quicker. We get about, it depends on the year, but we don't have a lot of calls that we get dispatched on a lot of calls. For example, last night we just had a request and it was almost immediately canceled a few minutes later. But this is a team that basically initially started as an amputation team, so to speak. That was the capability, was to be able to provide forward deployable advanced surgical and anesthesia into the field. So a CRNA and a physician model. Most of our physicians were either EM physicians or orthopedic surgeons. Dr. Pollock, you see his name on this paper, has been directing this team for quite a while, almost 20 years. So it's been in existence for quite a while. It's really designed for when we're looking to do prolonged field care. That's our model in Maryland to do this. We have very capable paramedics, as everybody knows. This team is meant to augment our EMS system. It's not meant to replace the providers or clinicians in the field. It's meant to augment that. The main capability has been amputations, but as in this paper, you'll see that we only had one amputation. So most of what is done with the Go team is advanced resuscitation, most of what I'm going to talk about in this talk are interventions that do not require the GO team. We'll give a good case at the very end. There's 2 cases we'll talk about today that kind of highlight this, but that's what the GO team is. Dispatched out from shock trauma, and we bring patients back. We deploy this as though we're actually have an operating room. So whoever's assigned to the operating room will go. That operating room then is reserved for the patient should they need an immediate operation upon return to shock trauma. So similar to our PJs, you folks have a very similar model to this, except that, you just do it all yourselves, in addition to extremely high level rescues, obviously, which goes far, far beyond. Thank goodness we don't have to deal with that component. But it's basically our answer to your model here in Maryland. That's kind of where we try to go with this. So let's just start off with the case. This is a recent case I was on. It wasn't it looked bad, but it wound up not being that bad. This is a 23-year-old gentleman who was driving a truck. I've modified some of the ages and a few of the demographic details just to prevent problems with HIPAA violations, but we're all professionals here, and we're just looking to improve patient care. So all of this is, certainly available for us to talk about. But 23-year-old male, prolonged extrication. They called the GO team. As you can see in the background, the clouds were pretty dense, so visibility was not good enough for helicopters. So we drove out to the scene. This is about almost an hour away. So this patient was trapped. You can see some of the pictures here. Here's some better pictures that show a little bit more of what the scene was like when we rolled in. You can see this is after the patient was removed. He was removed actually almost as soon as we arrived on scene, which is very typical. Our firefighters and rescue professionals are absolutely top-notch. And with today's technology, that's one of the reasons why the GO team just isn't really required a lot, is because they get people out of these types of scenarios. So this was a pretty catastrophic scene. As you can see, the patient, and well as 2 other patients, were trapped under that large crane apparatus that you can see here. Okay. And right here, and this was the scene getting the patient out. So patient gets into our ambulance, we perform our primary, secondary assessments, and clearly this patient, one would have to surmise, is going to be at risk for crush syndrome. So that's what we're going to talk about next. Before we do, though, a couple historical notes. So crush syndrome has been described for quite a while. One of the best descriptions from World War II. This is when patients were being pulled out of the rubble unharmed, talking, GCS-15, but later developed progressive limb swelling, shock, and they died of renal failure a few days later. So they were not walking, but talking, stable vital signs, only to succumb to renal failure and shock. So that's one of the earliest descriptions. Following that, we've had some more recent descriptions, such as the earthquake situations that have occurred and been well described in Turkey. This is the Bingöl 2003 and 2011, some scenes from these catastrophic earthquakes. The first one in Bingöl was a Richter scale of 6.4. There were 177 folks that died, unfortunately, with this. 625 buildings were collapsed. In a single dormitory boarding school, they had 84 fatalities. So absolutely catastrophic. You can see some of the rescue efforts here. This is a setup for crush syndrome. So that's what they were dealing with this. Later in 2011, they had a slightly higher impactful 7.2 Richter earthquake that resulted in even more deaths, 604 deaths. And then if you look at the Russian experience in Armenia, thanks to good advancements, which we're going to talk about here in the next few minutes, only less than a quarter of their patients required dialysis. But we're going to talk about what some of the threats are from these types of injuries. Obviously, physical trauma is the first one, and that's pretty straightforward most of the time. But what are the metabolic consequences of injuries like this? That's what we're going to really highlight here, talk about. So there's a couple definitions to get off to talk about. So crush injury. This just results from the physical damage from a crushing force. That's the crush injury. So that could be a damage to an extremity, could be damage physically to the chest, pelvis. Crush syndrome is really referring to traumatic rhabdomyolysis. And this is the breakdown of muscle cell components. And this is really what causes the metabolic disturbances. This is what is believed to have caused those deaths stemming from back in World War II and any major earthquake entrapment scenario. In Maryland, most of our entrapments are motor vehicle crashes, but certainly at a disaster level, this is the type of thing that you'll see in disasters. So crush syndrome is the proper term to describe the systemic manifestations. A couple other definitions are worth noting. Again, crush injury syndrome. Compression syndrome is also thrown out there as a term, and that's really referring to direct muscle injury from simple, slow compression that causes ischemic damage, interruption of blood flow, which can cause similar constellation of systemic problems. And then you have compartment syndrome, which is a rapid rise in tension in a muscle compartment. And I'll tell you that this is really not, I'm not going to focus on that. I think we have a few of our orthopedics colleagues from our GO team that might be on the call, so we can come back to that and talk about that a little bit at the end. But I'm going to really focus on compression syndrome, because again, that's the thing that's very amenable to some very basic interventions that are well within our scope of practice in the field. What's the pathophysiology? And I don't want to bore you with a lot of this. There's a diagram here that shows some of the components, and you can go back and review this. The bottom line is you get compression that leads to stretch and ischemia. And it doesn't take very long. I mean, some reports said up to 2 hours before you start having problems, but we've seen reports where up to 30 minutes you can start having crush syndrome. What's happening here is calcium influx, inhibition of your sodium potassium ATPase pump, decreased ATP production, neutrophils, free radicals. So once you're reperfused, that introduces oxygen back to tissues that were not oxygenated, and that can lead to formation of free radicals that are highly inflammatory, activation of proteases. So a lot of pathophys here that goes on, but the initial insult is related to that compression, stretch, ischemia, that insult that results in loss of blood flow. And then here's just another diagram showing more of that. It's important to note that not all cases of traumatic rhabdo result from a crush syndrome. We're really talking about a crush syndrome right now, but you can have traumatic rhabdo from being quote unquote found down. There's lots of other causes of rhabdomyolysis that don't result from crush syndrome, but they all share that same insult and resultant dehydration. See, these are folks that are entrapped for quite a while. Intestinal hypoperfusion. It can result in multiple systemic manifestations. The goal in all of this, the goal is to get them out, to rescue the patient, but to do so in a very deliberate manner that allows you to sustain the physiology and anticipate the metabolic problems you're going to see. The big one you're going to see that will kill patients is hyperkalemia. So when that oxygen gets reintroduced into the affective area, you get the superoxide radicals, liberation of free iron. All of this damages your RNA and DNA. But as this inflammatory process accelerates, you get a release of potassium from the cells. And you also get a loss of calcium. So the patients can become also very hypocalcemic. So this is what we'll talk about here in our management approach. When you're initially extricating a patient, this is the major threat that will kill them, that can kill them. Certainly, other things that are threats are hypovolemic shock and distributive shock. The reperfusion syndrome is something else we'll talk about here. And that's really, again, falls within the umbrella of a crush syndrome. But hyperkalemia, that can occur pretty quickly. So you're looking at less than an hour after extrication. Historically, that's what's been reported. Keep in mind that with severely injured limbs, it's been described in the literature that up to 12 liters of fluid can accumulate in these compartments. I know most of us in EMT and also in paramedic class, we talk about losing up to 2 liters of blood in a limb and a femur. And that's certainly true, but just remember that when you're really entrapped for a prolonged period of time, you can wind up with a large amount of fluid sequestration in compartments, such as the thigh or other extremities. So that's an important thing to remember. This is just a review for most of you, but it's important because recognizing this is going to be challenging in the field. You can preemptively treat the patient, and there's probably good rationale to do that. If you can monitor the patient, I say if, because certainly for our PJs, I don't think you guys are putting your life packs, your pro packs out in the field. You're probably not doing that until you get back to the helo or whatever vehicle you're using to transport. That's correct. But same with us in the GO team. We'll bring our monitor out, and actually our EMS colleagues will already be trying to do that, but we can't always monitor this. But once we can, and you should make every effort to try to monitor these patients who have been entrapped, this is what you're going to see. You're going to see the tented T waves. You're going to start to see loss of P waves. And once you start seeing a wide QRS, that's basically a pericode situation in a lot of cases. We don't have the luxury of, I'll talk about this in just a minute. We don't have the luxury of measuring potassium. For most of us, that's not a luxury we have. We do have that capability that we're developing on the GO team, and I'll talk about that in just a minute. But really what we have to rely on, I think the easiest way, the most practicable way to look at this is going to be via EKG. And so these are the things you'll see. I'm going to go back into this in just a second, because one of the questions I get asked is, we talk about calcium and bicarb, and how does that work? I'm going to tell you exactly how that works in just a few minutes here, just a second actually. Our Maryland protocol, just to review that for our colleagues that are on, obviously, this is it. So this is really under hyperkalemia, and you can see in parentheses, or crush syndrome. So if you suspect that a patient has hyperkalemia, these are the interventions that you're going to do. Clearly do all of your ABCs, primary survey, all that stuff. IV access is really important. I don't talk a lot about IO, but that's also a viable option. And most of these patients, that's going to be a challenge to get a humeral if they're really entrapped. Our guy was actually again, he was removed as soon as we got out. We were able to establish IV access, actually with ultrasound. It turned out to be a tough stick. But you could argue that whether you're going humeral, if you're going in the distal extremities, the question there is, okay, that's fine. You might be able to get to a tibia, but where is that blood flow going to wind up if they're crushed above that and have major vascular disruptions? Just something to think about. But in any event, one of your top priorities for these types of patients is to get IV access. And then start thinking about what interventions we can do. There's a couple simple things. Calcium chloride. We recommend pushing that slowly. We usually give 1 gram. Now, if you're giving calcium gluconate, that, due to the concentration of calcium, usually requires a 3-to-1 ratio. So almost 3 times as much calcium gluconate. Calcium chloride is much more potent. So what we're talking about here is 0.5 to 1 gram slow IV push. And the goal of this, and I'll talk about this next, is this is to stabilize the myocardium if you have hyperkalemia. And I'll tell you exactly how that works in the next slide. But that's a really critical intervention. If you don't have an EKG, you're highly suspicious that the patient has problems related to hyperkalemia or is at risk for it. You're in the process of monitoring them. Nobody's going to fault you for giving a little bit of calcium. Very little harm. Risk-benefit ratio is quite high. Maybe you don't give a full gram until you get your EKG on, or maybe some labs, but either way, nobody's going to fault you. And that's what our protocol supports here. You can consider bicarb, 50 milliequivalents, and amp of bicarb over 5 minutes. Give it a little faster than that. I'll tell you, in the OR and the ICU where I work as an intensivist and a trauma anesthesiologist, we definitely push it faster than that. So, but that's what the protocol says. Abide by that. And then albuterol is another option because that will help with some of the mobilization across the membrane of your potassium. So that's what we talk about. And then there is a discussion about bicarbonate drips. I'm going to come back to that because that is one of the controversial points with the management of crush syndrome. I'm going to argue in this talk that I think the primary intervention needs to be watching out for hyperkalemia and giving IV fluids. And I'm going to be very specific about how we can do that. Just to finish the discussion on calcium, because we do get asked questions on this. How does it exactly work? So everyone reads in textbooks, oh yeah, it stabilizes the membrane. Well, how exactly does that happen? Well, here's how it happens. So your normal potassium, you wind up with an action potential, which, as you know, that's the way that ATP gets mobilized and our muscle fibers basically contract. And cause an action, but it's all based on electrical potential. And so that gets thrown off a little bit here with this type of injury. Low potassium, you wind up below the threshold, okay? But in hyperkalemia, what happens is you wind up with a higher threshold. That dotted line, and by the way, that lower right corner of your screen, right here, you can see it. This is showing, the dotted line is showing a hyperkalemic effect. So what happens is, when your potassium's normal, you're not going to fire potentials. You're not going to have electrical impulses firing action potentials. But that gets disrupted in hyperkalemia because you wind up with all of this normal flow of calcium in, and then potassium in, all gets disrupted when your extracellular potassium is abnormal. And so what happens is you wind up with a condition where you could be at a higher threshold to throw an action potential. And that's where you can wind up with arrhythmias. The cells can basically fire more easily. Your sodium gates open and they don't close. And that's the problem that leads to cardiac arrest and to the EKG abnormalities that I also just showed you. So that's the actual mechanism. By giving calcium, this helps you reestablish this threshold. It lowers this line back down closer to normal and prevents you from firing off more action potentials. So there's a really good physiologic basis to use calcium. Again, I think the harm and the risk benefit are quite low. So if you're going to give any medication, that's probably the one you want to be thinking about in addition to your IV fluids. So let's talk about ISTAT and whether or not you want to use that. So I've been deployed PJs before. I think we had an ISTAT laying around. We didn't really train on it. I'm not sure, Colonel Rush, at the end of this, you can tell us what your thoughts are on this. I don't think in your environment this is a very practicable device. We did a study recently of over 300 patients for 2 years where we used this in our helicopters, had our paramedics use it. Here's the problem with the ISTAT. It actually gives very good results. I will say that. It's come a long way. It requires frequent calibration. So it's a good device, but the problem is it's very subject to vibration. And most people who haven't used this before don't know that it has a very narrow operational temperature range. So in the summer, we'd have to keep this thing near kind of an air conditioning inside unit. In the winter, our medics, or if I was with them, we'd literally put this in our jackets to keep it warm so it would work. Because it won't work. It'll just turn on and say below or above temperature. We have these devices allocated for use in our GO team. We haven't deployed them yet in our use. We've been talking a lot about this. I would argue if there's one situation that I had a need for an ISTAT. By the way, you can get lactate off this. You can get all of your electrolytes. You can get a hemoglobin level. You can even get troponins. It's a very capable device. The problem is just that. When do those things really change management? I would argue lactate. That's a separate discussion. Sure, maybe that one could be a trigger for a hemodynamically stable patient that might need a blood transfusion. I would say in crush syndrome, that's probably where I see this thing coming into play. If you are at a scene, maybe you're at an earthquake, building collapse, motor vehicle crashes, probably not as common, at least for the GO team, it hasn't been for us. You're really on the scene for that 2-hour period. This may be of value because you can measure, if you can get a blood sample, you can measure the potassium. So it's something to put out there, lots of limitations. We can discuss this maybe at the end, see what your thoughts are on it. Got a lot of experience using this device. Also in the military, we use it in our CCAT teams and also when you're deployed. So it's a good device, has some limitations. And there's really not, to my knowledge or experience, there's a new version of the ISTAT that's supposed to be more resistant to some of these issues. But overall, there's not really any other better device. There's not a point of care potassium test. There's AccuChecks you can use, but those also require a lot of calibration and QA. So not really deployable. This is the most commonly used thing you might see, at least in the US. So just to go back to this, because this is what I live with in the ICU, here at Shock Trauma, we wind up, once these patients are brought to the hospital, these are the things we can deal with on the back end. And we can talk about this more at the end if you want. But just suffice to say, these patients are at really high risk for things like ARDS. shock liver from hypoperfusion. The amount of volume we're giving these patients, as we'll talk about next, is very high. And if their kidneys shut down and we don't catch that and we still keep giving them volume, that's one of the mistakes you can make with this syndrome. You can actually have, you can put fluid overload them very quickly. In fact, when we're following CK levels, if your CK is above 5,000, and that's not really a very high level, by the way, above 5,000, you've got about a 1 in 5 chance of going into renal failure. When I say renal failure, that means usually requiring dialysis of some form, okay? At Shock Trauma, our preference is to just put most of these patients on continuous renal replacement therapy, just because we have to control their electrolytes a lot of times, and also to remove volume. We can ultrafiltrate them. They can also be prone for things like disseminated intravascular coagulation. Compartment syndrome is always a threat with these patients. So once they get to the hospital, it's not something you're going to be able to measure in the field, and we'll talk about some of the recommendations on this in a minute. But compartment syndrome is something you've got to be acutely aware of as well, okay? Here's a really good flow diagram, and you'll have this paper at the very end, like I mentioned, you'll have this reference. It's an international reference. So try to find a vein. This is before extrication. If you need to put an IO in, that's fine. You know the flow rates are going to be slightly slower depending on your diameter of your IV that you get. But if you get a good IV, great. If you get an IO, also great. Once you do that, our recommendation, I say our recommendation, the international recommendation is really to give 0.9% saline at 1 liter an hour. That's the infusion rate initially. While you're extricating the patient, you can continue that. If you're looking at a 2-hour period of time where you're trapped and you're trying to resuscitate and give this volume, you might want to reduce that around hour 2. After hour 2 of 1 liter an hour, that's 2 liters that have gone in over 2 hours, we recommend that you go down on your infusion rate to 0.5. And the reason for that is because, there's lots of reasons for that. You don't want to fluid overload them. You probably are challenged with assessing them if they're still entrapped, but really you need to make an assessment before you continue to give that fluid. And that's where we don't want you to over-resuscitate. That can be a problem as well. But it does require, this is a fairly large amount of fluid. I mean, this is not a rate we would ever put anybody in the hospital on regularly. Also, many of you are familiar with all the controversy about saline. Notice how I don't say normal saline. There's nothing normal about normal saline. It's got 154 and 154 of sodium and chloride milliequivalents. So that's a pretty high chloride load. Not great for the kidneys. The problem is we just don't have any other good solutions out there that don't have potassium in them. You can't use, they really recommend against using lactated ringers. We recommend using plasmolite, which we use here at Shock Trauma. Those solutions have respectively about 4 milliequivalents per liter and 5 milliequivalents per liter of potassium, which isn't a lot, but if you're giving a lot of this fluid to someone and their kidneys are starting to shut down, that can accumulate and you can definitely put them into hyperkalemia. So that's a relatively strong recommendation not to use potassium-containing fluids. Only use saline, 0.9% saline. After you extricate, it depends on the clinical condition. We really do advocate, and we carry Foleys in our kit for the GO team, but in the field, most of our EMS providers are not going to be able to quantitate urine that easily. One of the things you could consider is putting on a condom catheter or a Texas catheter if it's a male. That would help you quantitate the urine output. If the patient's talking to you and they can urinate, if you can capture that, I know it's dirty and disgusting, but that's actually very helpful information for us to know what their urine output is, because once we get them on the hospital track, that's what we're going to be tracking on. If they're anuric, we're going to start limiting their fluids and stop this fluid resuscitation and move to dialysis. That's what we'll do. So the decision point is very much contingent on not just the labs, but are they physically urinating? So if you can monitor that, great. I think for our PJs, I think for most of our pre-hospital providers, this is not going to be something within your consideration unless you're doing something like prolonged field care. Well, in that case, you may be. So early IV fluids are a hallmark. So as we've talked about, calcium and early IV fluids, 0.9% saline. Recommendations are really to get that urine output, preferably if you can monitor it. We're looking for a urine output that's really high, 300 mils an hour. And this is fairly well evidence-based. I've got several references there. The reason this is evidence-based and where they've really determined that this is helpful is through those earthquakes that I showed you. Bengal, 25% rate of folks going on dialysis. Compared to other earthquakes where they did not use IV fluids, the rate for dialysis in those patients was over 70% in many of those studies. 60 to 70% of those patients required dialysis, those that did not get IV fluids. So this is absolutely a life-saving intervention. It's definitely an intervention that will prevent morbidity from going on dialysis. It's a costly and very labor-intensive intervention that does have complications occasionally. So if you can prevent that by just doing good hydration, that's a really important intervention. Simple but important intervention. And again, they talk about decreasing the rate once you're ready to do that. Okay, so let's get into some controversial things. I know there's questions out there that you're probably asking. So what about that guy that was trapped? Should we have put some tourniquets on him if, let's say, his leg was entrapped? Should we have prophylactically put a tourniquet on to prevent those bad humors that are building up because of lack of blood flow? So as soon as he's released, all that stuff's going to reperfuse. So it would almost be intuitive to think about using a tourniquet. Well, as it turns out, they're not recommended prophylactically. Again, I have all the references here. One of the big ones is the Seaver reference from 2013. That's an international reference, which I'll show you again in just a second. Really don't recommend doing that unless you need to use the tourniquet for other reasons, obvious reasons of blood or bleeding, okay? Those would be reasons to obviously do that for hemorrhage control. Mannitol. So mannitol is really not indicated in the field. You may have it. We have it in our Go Team pack. You can consider using it to improve urine output. Really, though, you need to be doing regular fluids first, not going right to mannitol. And it can be useful to help augment the urine output. It's controversial, and you can see my red quote that I have here. Just no good data to show that that really helps prevent renal failure, mortality, or the need for dialysis. Now, sodium bicarbonate also has a role because it can help with the hyperkalemia, so that's true. There's not great evidence that it improves outcomes, but it will help your physiology a little bit. So that's actually not a terrible thing. You can see in our Maryland protocol, there's a consideration for it. The protocol acknowledges that that's not a high-level intervention, but nevertheless, it's something you can consider if you have the capability to do it. And the way we usually do that is we put an amp in, preferably in a half normal bag of saline or 0.45% bag of saline, and then we can run that alternating with a bag of 0.9% saline. That's one way you can administer it. You can also just push an amp slowly. That's another option. But here's the thing with large doses of bicarb that you got to be careful about. It can worsen hypocalcemia. And hypocalcemia is already a problem that we're dealing with, and I worry about that. And it can also, if they're having any kind of respiratory compromise, the CO2 that gets associated from that can wind up also being a problem. So you got to be careful with bicarb. I can't give it a really high recommendation based on the literature. But if you were to consider it, and if it's in some of your local protocols, fine. It's in ours in Maryland. You could consider it. And then the whole idea with bicarb is, what are we really trying to do with bicarb? So what we're trying to do is prevent precipitation of proteins and cast formation. So this can actually decrease the release of free iron from myoglobin. And all this stuff has been shown mainly in animal models, not as well in humans. And so once again, you see the formula there that you can implement if you want. You can alternate a bag of 0.45% saline with an amp of bicarb added to it with a bag of regular isotonic saline, 0.9% saline. The problem is if you put bicarb into a bag of 0.9% saline, that's really a hypertonic solution. You just have to be aware of that. That's what you're going to wind up with, because it's a large sodium load in sodium bicarbonate. It's a large osmolar load as well. So we prefer trying to put that in a more dilute solution. 0.45% saline, though, is not something that's readily available in most EMS systems, I would argue. At least not in ours, to my knowledge. You guys can speak up at the end and let me know what your thoughts are on that. Our targets for this, and this is more when you're in the hospital, once you're in the emergency department, is a pH less than 7.5. We don't want to make patients too alkalemic with this. We want their pH around 6.5, and we want to make sure their calcium is being monitored, because like I said, this can lower your calcium. So it's a bit controversial. If you look at the international, so this is a tongue twister here. This is the Renal Disaster Relief Task Force of the International Society of Nephrology. So crush syndrome is really seen as as basically a renal emergency. That's what it's seen as. And so they recommend the same things we discussed. If you have, by the way, children or elderly patients, you might want to reduce the dose to a weight-based dose, 15 to 20 mils per kg per hour, and then reduce that dose further down to 10 mils per kg per hour after that first 2-hour period. Definitely giving fluids during extrication whenever possible is recommended. On-site amputations are not indicated to prevent crush syndrome, only to get the patient out. And then, by the way, if you're doing that, whole nother protocol that you guys are familiar with, and again, we can talk about that case, you would apply tourniquets and be ready to do that, obviously, for an amputation. But the idea of just amputating the limb to prevent crush syndrome is not an indication for that. The indication is to actually rescue the patient from the entrapment if you cannot do it with other conventional rescue techniques. Don't recommend applying tourniquets. They do recommend treating hyperkalemia as early as possible and being very vigilant for this. So once again, to foot stomp, fluid resuscitation, key to preventing renal failure. Hyperkalemia is what's going to immediately kill a lot of these patients. The principles overall are to really get at that fluid resuscitation, get access if you can, and try to do that. Things that you might want to consider, these formulas of 1 liter per hour for 2 hours are not cast in stone. If you've got an elderly patient, if you've got a patient who's not been entrapped for very long, if you've got a patient that you can measure urine output, if they're under there for a long time and you're able to get some kind of Foley or device, or they can pee and you can measure it, not a common thing you're going to be doing, but if you can, these are things that could help you individualize fluid titration. Just like with burn patients, you should be checking the patient every hour and making some assessment to see where they're at with this. And just remember, if they're cold and hypothermic, which many of these patients will be, less fluid in that condition as well. You're going to down titrate accordingly. So that's what I've got. Let me just highlight one more case that's a little bit more in a different direction. So our patient, going back to that initial patient, he was fine. He actually didn't have, he did have rhabdomyolysis. He was in the hospital for 2 days. He got fluids. We gave him fluids en route to the hospital. He was maintained a good urine output, left the hospital without needing dialysis. I think we probably could have given him a little bit more fluid. He's a big guy. But overall, we didn't have to do much. We did a lot of ultrasounds en route to make sure we weren't missing anything, fast exams, but we really couldn't find anything that was requiring any immediate treatment. He did have a couple minor fractures, but definitely had some soft tissue damage, and he did very well. This patient is a totally different patient, 70-year-old patient who crossed lanes, crashed into a guardrail, was reported to be impaled on the guardrail. We weren't sure what that meant. This was a prolonged extrication, 45 minutes. So we were activated for this, but this was fairly far away from shock trauma. So this is definitely a 20-minute flight, which is, you can imagine, pretty far from Baltimore. And so we were canceled en route once they got him out and they brought him to a local hospital. The problem with this case was the patient wound up receiving at some point before going to the OR and on the scene, a total of 6 liters of fluid. And so I get it. I mean, he was hypotensive. He had other injuries. Here were his injuries, by the way. He had an injury severity score of 66, which, by the way, if you remember, 75 is the maximum score. Severe trauma to his pelvis and extremities. He got damage controlled at the outside facility, multiple procedures in one operation, XLAP, pelvic packing, massively transfused, 19 units of red cells, 8 FFP, and 2 of platelets. So that's a couple blood volumes that they replaced. And then he was transferred to us, got multiple operations, became progressively acidotic, hypoxemic, ARDS, all the manifestations I showed you on the slide a few minutes ago, this patient had, and he did die. So what could we have done better in this case? And we've scratched our heads and we've talked about that and reviewed it. And I'm not sure. I mean, was giving all that fluid up front a great idea? I think it's all that our folks had in the field. I don't fault them for necessarily doing that, titrating to some kind of blood pressure that they were trying to achieve. They didn't have blood products. I think this case makes a good case for giving blood products in the field. It also highlights a really important principle with crush syndrome. yes, crush syndrome is a metabolic problem. It's usually a renal problem. But if you think about the energy that was required to cause that, you can't miss other concomitant problems. So other traumatic injuries, such as what this patient had, abdominal injuries, other sources of hemorrhage. Our argument, I think, with this is a great example for blood in the field. If we could have done it, and we're working on that here in Maryland. PJs, you guys got this. This is a guy that you'd be probably resuscitating concomitantly with some fluid in a balanced approach with blood component therapy, perhaps, and trying to do some damage control resuscitation. So difficult, complex case. Definitely highlights a little bit of over resuscitation with fluids, at least up front, which caused a lot of dilution, which led to probably more bleeding. And then by the time he got to shock trauma, was very physiologically deranged, but also, not the youngest patient with a lot of physiologic reserve. So just to put that one out there, this was not a go team call, but just another case to kind of highlight some of the complexities that we've seen with this. So to summarize, the two things I think I've said plenty here: fluids, hyperkalemia, that's what's going to kill your patient. Prophylactic tourniquets are not recommended. Mannitol bicarb are optional, not always practical in the field. Bicarb might be practical in the field, depends on what you're capable of doing. So with that, I'm going to stop here. So on this screen, there's a link to all the files, including the references, PDFs that you'll have available. So if you click on that link or copy it down, if you have a cell phone and you want to take a picture of the QR code, that'll bring you directly to the folder. It's a Dropbox-based application, basically like a mini website that gives you access to this lecture as well as all the references. So with that, I'm going to stop. Little over 40 minutes. We got a lot of time left to answer any questions. So I'm going to go ahead and mute myself. Or actually, we can unmute folks, I guess, and see what you think. Thoughts? Questions?
Sam, hey, this is Jed talking. Hey, thanks for the lecture. Thanks for inviting us over. It was awesome. You mentioned something about the ISTAT and monitoring or trending lactate. I saw something, I don't know if it was in a lecture or if it was in a paper, about the trending lactates versus tissue perfusion capillary refill, especially for us in like a prolonged field care setting, as far as a resuscitation without an ISTAT. What are your thoughts on that?
Yeah, I think that's a great question, and it's been looked at by several folks. There's a couple papers on that I could certainly send your way. I think it's a great idea. I think, I'm always cognizant of what you guys do. I'm cognizant of our pre-hospital providers in Maryland as well, clinicians, because it's whenever we start talking about point of care tests, there's a lot of QA that goes into that, and you want to make sure your result's accurate, right? I mean, you don't want to be acting on a lactate that's 6, but it's 6 because it took you a couple minutes with a tourniquet on to get the vein. I mean, that's the problem I have, I think, a little bit with the point of care stuff. As much as I am a very much an advocate of it, is it's probably the best we've got if you're going to get at a real physiologic measure. There's lots of things that can increase lactate. I think there's going to be a lot more point of care lactate devices. We actually have one. So I didn't talk about it, but in this case, we actually did a point of care lactate for that with the Lactate Pro meter. Again, no disclosures, don't have any stock in that company, but you can get a finger stick lactate or a single device lactate and follow that. Tissue perfusion is really, I wish I could give you better data on that as well. We tried, that was part of our study we looked at in our patients in the field, and that was really geared at trying to give you guys some tools as the PJs. Because quite frankly, it would be great if you could put something on your thumb and follow tissue perfusion, right? Tissue oximetry. That could give you a good insight into the microvasculature. Fortunately, it didn't pan out. The devices all broke and they weren't accurate. So we don't have, at least I'm not aware of any great tissue perfusion monitors that are ready to be, for you to take on your next deployment. I think lactate's probably the best way to go. The problem is if you're going to get a lactate off an ISTAT, it's kind of a sledgehammer approach. You can get it off of a CG4 cartridge, and that's expensive. It requires a lot of QA. You'll have to have someone at your unit that's constantly QCing these devices and making sure, even every day, making sure they work. So maybe if you're deployed and you want to keep one in the back of the helicopter, but it's one more thing you got to do that's a little bit tough. I would advocate, to answer your question, maybe a more point of care single, either the Lactate Pro or some similar device. The problem with those devices, the last comment I'll make is a lot of them are not FDA approved. They're usually for athletes to check their lactate after like hardcore working out. I think the other things you can use are shock index. I think there's some ultrasound indices that we could talk about that are also helpful. There's other ways to get a perfusion. Cap refill is still an oldie but goodie. So these are all other things you can use in your armamentarium.
Awesome. Thank you very much. Thank you. I appreciate it.
Sir.
You can talk.
I had a question. So I was interested in with crush syndrome, compartment syndrome. Well, with a crush injury with compartment syndrome, bilateral gluteal compartment syndrome (BGCS). Is that something that happens a lot, or is that pretty rare?
Yeah, no, that's a bad one. So that's a great point. I'm glad you brought that up. So that is absolutely something we see. Where do we see that? I'll tell you a couple places we've seen that we weren't expecting. Some bariatric surgeries where patients on the table for a long time. We've had a couple really bad cases of gluteal compartment syndromes. It's a really challenging one to. It's a great example of why you really need to. Once you get these patients extricated, you really have to do a good, solid secondary survey. What you might find are some tenseness back there. You might see some swelling. Basically, you're looking for a tense compartment. It's hard to diagnose, though, if the patient's obese. It's really difficult. You really need to have some physiologic measures at hand. So that's the patient so the patients I've seen with that are ones that extricated, yeah, probably at risk for rhabdo, probably at risk for crush syndrome. But it wasn't until we got the labs back that we started seeing CKs and myoglobin levels that were really high. Right. And then the question you have to ask yourself is, what compartment am I missing? And it's not always just the gluteal. We've had some psoas compartment syndromes that have actually occurred in really big folks. So a compartment syndrome is not just always an extremity. It's a great point. You can absolutely have gluteal compartment syndrome. And you have to, the way to key in on it is by your exam, which may not be very revealing at first, and then ultimately with lab results.
Thank you.
Resuscitation for that, by the way, is very similar to what we're talking about. Same threats to hyperkalemia, good fluid resus.
So, and even guess rarer case, the psoas can get. I hadn't realized that because it's so deep in there, and I think people often forget about the psoas and how important it is, particularly for functional exercising.
It's a huge muscle, right? Where we've seen that is in a couple of really big patients, muscular patients. Like I'm talking, no kidding. I don't want to violate HIPAA, but let's just say they were athletes, and they had some abdominal compartment syndrome also going on, and also some just overall inflammation from other conditions, but it led to an internal compartment syndrome of that muscle. It can happen, and you don't find that one unless you can scan them in a CT scanner, or at least you see your CK and myoglobin. That's our question we ask in the ICU and in the ED. We say, wait a minute, we've got a myoglobin of 15,000. I've checked all the extremities. They're all soft. I don't see any obvious fractures. What's going on? What am I missing here? And that's where we start thinking about things like gluteus. You roll the patient, check the back. Is there an internal compartment syndrome going on? Not that common, but certainly something you wouldn't want to miss.
Thank you.
Hey, Sam, it's Steve Rush. I have two questions for you. That was a monster of the best crush syndrome talk I've seen. So that we appreciate your having us on for real. The first question is, have you had, in your experience as an intensivist, so we definitely do not use the iStat for a whole variety of reasons, including environmental liability, but have you seen instances where people have cardiac symptomatic hyperkalemia without having peaked T waves? So we do tell the guys to bring their ProPack out to the field if it's going to be a prolonged extrication and watch for that. So is a peak T wave like 100% that you'll pick it up in advance, or is that a reason theoretically really to have an iStat? That's the first question. I'll let you answer that.
Sure. Yeah. The short answer is no. EKG is not 100%. And honestly, it depends. It's a lot of factors with that too. I mean, sometimes just the lead placement can be a challenge, maybe incorrectly placed leads. But I think trying to perseverate on that, and that's why I am an advocate. If you have time to get a level, it's great, but it's the only thing we really do have, though, physiologically, outside of doing a point of care test. But your answer to your question is you can absolutely have, and I've seen this many times in the ICU. In fact, let's say that we have a patient like that last one I presented there who's older. Again, probably not your population, but who knows? I mean, PJs can take care of anybody. So, I mean, anything could come your way. But let's say you have a patient with some comorbidities, and maybe they have some chronic renal failure, chronic kidney disease. A lot of those patients live with fairly high potassiums, and it's not going to take much to put them over the edge. Their EKG will oftentimes be completely normal looking. So I can't give you the percentage. I could look that up and try to find it, but I can tell you from experience, absolutely, you can have hyperkalemia without the pathognomonic spike T wave.
And does that also go for, you can still get dysrhythmias without the peak T wave? Or should that really precede a dysrhythmia theoretically?
I mean, you can definitely get dysrhythmias. And the other reason for that is for all those other inflammatory mediators that we were talking about there. Well, I tried to be brief about that, but there's a ton of them. I mean, you've got purines, you've got all kinds of free radicals. So you can absolutely wind up with dysrhythmias that are not related solely to hyperkalemia. However, in this clinical circumstance, the most common electrolyte that's going to cause problems for you is going to be hyperkalemia. That's the one you wouldn't want to miss. If there's one thing after the call that you're thinking about, that's the one that you don't want to miss. But you can absolutely wind up with a lot of dysrhythmias. We see these patients, sir.
No, and while you're on the potassium, do you rely on sugar at all to help with that D50?
Great question. That's a great question. So there's actually descriptions as well of using a dextrose solution if you have it. I didn't put it in this talk because in Maryland, we don't really carry those solutions. Most of our folks do not carry those solutions. But certainly, as we all know, that's one of the things we give insulin. We can give, we want to chase that with glucose. Even some argue just giving glucose can stimulate enough insulin internally, right, to help cause that movement. So the short answer is certainly if you have glucose containing solutions available, I think that they can be recommended as well. And that's another thing that's talked about in that guideline I showed you, but it's really kind of buried down there because they're really trying to target a lot of the guidelines towards the major earthquakes where resources are going to be limited. But if you're going to fine tune your approach, absolutely, if you've got a glucose containing solution, you can consider it. In the ICU, we would probably transition into something like that fairly quickly.
So my nephrology buddies feel pretty strongly about that. And for the paramedics, other paramedics out there, we use a mnemonic called CRASH for crush: calcium, run, saline, albuterol, sugar, HCO3 bicarb, just as a mnemonic device.
Yep.
And we do see elderly. So that was the Haiti earthquake where we had PJs responding with FEMA. So we definitely can have that. The final question is, and it was shocking to me, quite frankly, was how strong is the data on tourniquets? Because both our protocols and the SOCOM protocols and FDNY, we're all still using tourniquets. And if you tell me that data is strong, we're in the middle of our handbook revision, I'm going to cut it out. So
yeah.
That was awesome to hear.
Are any of my other colleagues from the GO team on this call? Vitberg, Dr. Vitberg, or anyone else?
Sword's here.
Oh, perfect. What do you, I'm not trying to punt that to you, Doug, but I can tell you one thing, Steve. I can tell you, I pulled that right out of the guidelines. I think that their concern is that the tourniquets will be overused. I will tell you, I was brought up trained to put a tourniquet on, basically, to prevent the bad humors from getting flushed back in the system and causing a reperfusion. And you leave it on until they get to the hospital. So I hear what you're saying, and I'm just giving what I think we need to probably look at the references for that reference and see if that's really robust. I think what we're trying to teach is just not to put prophylactic tourniquets on extremities that may just look a little swollen. I think that's the intent of that. But that's a good point. Doug, what do you think? What do you think on that?
I can't speak to the data without spending some time looking at it in
Yeah.
detail with that question in mind, but it seems reasonable, and I think it's been listed in a couple of the references to at least place a tourniquet and not tighten it down, so that when you pull the patient out, if they're hemorrhaging, when you pull them out, because you've now released them, the tourniquet would be ready to go. So I personally think that would be a reasonable approach.
But Steve, you're saying that what you're talking about is really for crush syndrome. It's more of a prophylactic measure, preventative measure. Is that what you're? Is that what's in
Yeah.
your,
So we put it on at the time of the lift pillow or whatever extrication they're going to do to reduce the reperfusion injury. But then after that, nobody knows when to take them down anyways.
Yeah.
I'll look at that with you because I've just been taking that on gospel, quite frankly.
Sure. Good question. Yeah, I'd be happy to. I'd love to dive into literature a little bit deeper on that as well. I probably should have done that before I put that out there. But this guy Seaver is really one of the world's experts on this stuff, and you'll see the name and all, both the the ISN recommendation. You'll see it. There's a lot of almost everything that's written about this. You're going to see a reference, and that's where that came from. So we'll have to look at the literature a little bit more, see if that's substantiated. All right, any other questions? We're just about 4 minutes short of 4. People got a lot to do, I know, with this COVID stuff. We're all ramping up for that.
Sam, this is Doug. I just had a comment on the capillary refill that was mentioned early on in the questions.
Sure.
And from my understanding, what the papers that I've seen, it's really been in reference to sepsis and helping, decide how much fluid to give. And I don't know, it may well apply to crush or to trauma in general. I'm not sure, but what I've seen recently has been really more of a sepsis-oriented discussion on that.
Yeah, I don't know. I mean, it's free to check. I guess the question is what you have to take into account to the extremity that is you're checking it on, just to make sure that's not compromised. I just think it's another free thing. I mean, every patient I walk in on, I try to check the cap refill nowadays. I just think it's one more free thing. I wonder with some of the early perfusion monitors if they were just really expensive cap refill checkers.
Yeah.
But I'm still hopeful to get back to that initial question. I'm hopeful we'll get a good tissue perfusion monitor. We have technology in the lab that can do this really well, but to get a handheld, robust, something we can throw in the back of a helicopter or ambulance, I'm just not seeing it. I mean, the one we had from Hutchinson, that they all broke within like 3 uses, and they weren't being manhandled. They really weren't. So I'm still hopeful for that technology as well. I think that can help inform some of these discussions about fluid titration and perfusion, but it's just haven't seen it for prime time in 2020 quite yet.